denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva sucedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial, parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire ?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm a critical care nurse. I'm proud to work together with other professions as a multidisciplinary team to fight COVID-19. Together, we are intensive care.
I am an anesthesiologist and I'm proud to be an intensivist. Together we are fighting COVID-19. Together we are intensive care medicine.
I am a critical care nurse and perfusionist. I am proud to work in an intensive care unit. We are working together to fight COVID-19 and together we are intensive care medicine.
I am an internist and I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Welcome everybody this afternoon to the latest in our webinar series looking at the impact on patients and families during COVID. During this webinar, we'll be looking at debating with you, the audience, some of the short and long-term impact on patients and their families during COVID, talking about difference in visitation practices and how we can support patients and families after their ICU stay. I'm joined with a group of friends and experts who are very well placed to be actively discussing these topics. So we have Professor Julie BENBENISHTY, who is a staff nurse and a post-anaesthesia and surgical intensive care unit in Hadassah, Jerusalem. My good friend, Dr. Andre Michelson, who's a consultant in anesthesiology and critical care from Konstanz in Germany, and Dr. Christina Jones, who is the research manager at ICU Steps, who support patients and their families as a peer support charity during recovery from critical illness. Welcome, everybody. What I'd just like to say to the audience is please do post questions on the chat via whichever medium you're looking at us on, so that via the ESICM TV chat, via Twitter, Facebook, YouTube. This is really important that we get people engaged and we can really discuss and debate our experiences and our thoughts with our experts on this really key topic that we've all been living through for the last 14, 15 months with COVID. I'd like to start off by just asking our panel just for their thoughts on the impact from their perspective on patients and relatives during this COVID pandemic. I don't know if Julie, if you wanted to start.
Okay, hello everyone. I think as we evolved through the COVID waves, we saw a dramatic dynamic change in how we related to families of patients. I think everywhere around the world during the first wave, when the pandemic really erupted, there were no families, the hospitals were absolutely closed, and there was even an enforced isolation. And people kept home, and they were even afraid to even socialize with people who work in the hospital. So families stayed away, and this was terrible for the ICU staff because we didn't know the patients, and it was very hard for us, and many, many patients died with no families. As we evolved to the second wave and more people had contracted COVID-19 and recovered from it, they felt free and able to come to the hospital and visit their loved ones. So more and more people were coming to the hospital. And I don't know everywhere else, but we had a whole wing of the hospital just for COVID-19. So we had no physical place for the families to be. And there was no one, everyone was inside the COVID, and there was no one really relating to the families or communicating with families. So we had to develop, there was a vacuum, and we had to develop how we're going to contact and talk and deal with the families. So we had this dynamic change. And of course, by the third wave, we had people in the hospital all the time, and we had families parked outside the COVID-19 ICUs constantly. And they want to come in all the time. And we almost had no control of how we could deal with the families. And I think just thinking about that, how everything changed from the first wave to what's going on now, we see a huge difference in how families and visited their loved ones in COVID-19.
Okay. Andre, do you want to give your sort of précis of how you found it for patients and their families?
Yes, thank you. Good afternoon or good morning from wherever you are listening to us. I think that COVID struck us and struck the world in many ways. And it struck the patients and their families and all the healthcare staff. To my assessment, first of all, we were all struck because we really didn't know what to do in the beginning, which is not a very good situation because you're trying to help people, but you do not have the recipe yet. That is contrary to what very often happens, that we still have the confusion and the angst and the anxiety, but we usually know what to do. Here we didn't. Which means that we had to say often to patients and their families, really, we don't know. We try to help you and we do what we think is similar to something else we've been doing. It may work, it may not work. And that, of course, causes confusion for all involved. We got a little better. We eliminated a few drugs that were shown to not really help. We have a very few drugs that we think and understand that they do help. So that got a little better. I think we also got better in terms of when to intubate, when not to intubate, and that took away some anxiety on both sides of the staff and on the patient side. However, as Julie has already described, in the very first wave, also in Germany, we were very critical on who would be allowed to come into the hospital. And we were quite restrictive, as I may say that, although of course I'm not representing the whole of Germany, but there's a few clinics that I do know. So we let in, if you will, only families, either if the patients were almost about to die, or husbands of women who gave birth to their babies. So there was an isolation for both the families because they were told to stay at home, and the patients because the families couldn't come. And that put an extra task to the staff because now they suddenly also became visitation managers, so to speak. So on top of the medical care that they had to deliver, with in the beginning not knowing what to deliver really often, they suddenly had to be the liaison person between the families and the patients, which often caused, I think, moral distress because we all understood that we couldn't do what we all wanted to do in the time that we were given. Especially on end-of-life care, it was very difficult because how do you explain that by telephone or by a computer when a patient is really approaching the end of his or her life? So I think we do see not only patients with a post-intensive care unit syndrome and even medically speaking, post-COVID-19 syndrome, but we also would see post-intensive care syndrome family. The next waves were a little better. We were able to allow a few more families into the ICU. What got more difficult, at least in Germany, is that we had, and I think I may say that, a hampered start into the immunization process, which means we did not get a reasonable number of staff and or patients and or families immunized, which means we still had to restrict. So we got this difference between the public opinion saying, well, now you can immunize. Why are not getting any further? Why can we not get into the hospital? And us having to say, yeah, but you're not immunized, but you're only immunized once. But the time from the immunization to now has not really evolved. So we had, if you want to call it like that, an extra stress or stressor. That's going a little better at the moment, yet concluding this pandemic was more a social thing that we hadn't dealt with on top of medical problems.
Thank you, Andre. Christina, what's your experience been in the last 15, 16 months?
I suppose for us, I mean, our primary goal is face-to-face support groups for patients and relatives. So they had to go straight away. And for a little while, it was scratching our heads, what do we do instead? And very gradually, we have about 23 local groups around the UK. And some of them just had no wherewithal to be able to do anything virtual. But there was particularly ICU Steps Chester, they started Zoom meetings once a week for patients and relatives. And they also started a relatives group for relatives where this patient was still in intensive care. Because one of the things about sitting in a relatives room, waiting to speak to a doctor, is that you talk to other people. And if you can't go and do that, you lose that support of other people around you who are going through the same thing. So very gradually over the months, the number of meetings started to increase. And it made sort of a nonsense of having local groups, because people could actually, we had people joining from America and Africa, and so really geography no longer mattered. One of the things that I worry about are the people who don't have any sort of technological bent. We do try and talk people through the process of how to get onto Zoom and and there are still people who several weeks down the line still, manage to talk for 10 minutes on mute, even though you're desperately trying to tell them that they're on mute. But it just about works. And in fact, a couple of weeks ago, one of the groups had their first face-to-face meeting. It was outside on park benches, but it did work. So the whole charity, the way the charity has worked, it has changed completely. We've also had a lot of inquiries. We have a contact page on our website, so that people who are really distressed can contact us and say, I need some help. And our trustees are divided into patients, relatives, and healthcare professionals. So very much the healthcare professionals were picking up those inquiries because it was too distressing for the patients and the relatives. And some people were really desperate. In fact, one lady, she emailed me and then said, I'm getting really desperate. You have to phone me, you have to phone me. And then when I tried to phone her, she didn't answer. So in my head, I thought she'd committed suicide. I was so worried about her. So there was quite a lot of stress for the trustees as well of the charity. And we've had to form a WhatsApp group basically to support each other, where normally that wouldn't have been a problem. And a few people have had to say, right, I need to take a week off because I just can't cope anymore. So it really has completely changed the way everything works. And in fact, strangely, some groups are actually saying that they want to continue to have an element of Zoom in their meetings, because it has allowed people who have just left intensive care to actually join meetings, whereas normally they would find it too much to actually get to a physical meeting. So if we go back to physical meetings, there will be Zoom in the background for people who basically can't manage to get there. So really everything has gone out the window.
It's kind of shaken out what we've all been doing for many, many years. And I think we've all realized how innovative that we can be when all those normal tools have been taken away from us. We've got some questions coming in from the audience, and the first one is what would the message from all the speakers be to those countries who have strict family visitation policies prior to C-19? What would their message be in terms of making sure that people are supported? I don't know which country that they're talking about. I'm guessing some countries have very strict visitation rules in normal times, never mind COVID-19. What are your thoughts on that, the panel?
There's been a lot of research done showing that open visitation is so good for families, and the staff has to know how to deal with it. But once you show and demonstrate to the staff how good it is also for them, what benefit the staff is getting, we know from the research that families and patients benefit from open visitation. And it's usually the hardcore staff that don't want to change. So, Christina, you ended with there's a lot of things that have changed, but it has also opened opportunities, new opportunities that weren't there before. People from America can now hear and join in ICU steps in the UK, which was not there before. So this is an opportunity for us to think about open visitation, but we know it benefits most people.
Sorry, go on.
No. Ladies first. Sorry, Christine.
Thank you. I think one of the things that struck me is relatives missed just actually being able to do little things for the patient, moisturising the skin, things like that, of being by the bedside and being able to do those things. I think if you've got a very short visiting period, you don't have the opportunity to do that. Even in normal times, you can't do things like a little bit of self-care, look at the eyebrows, things like that women certainly very much appreciate. It really strikes me that visiting is so important, and it's just shown how important it is.
Andre, what do you feel?
Oh.
I can't hear you.
Sorry, I'm saying I'm agreeing with Julie that this difficult period gives opportunities, because if we were to agree that certain patients have a somewhat higher need to be able to be visited, to be allowed to be visited, then perhaps the idea of getting overwhelmed by packs of visitors can be diminished. And I think certainly very sick patients, or again, men whose women just give birth to their children, should not be excluded. And then you have to get tested, which was a big step forward in our country, that once visitors could be tested, and so nobody was afraid from both sides, that really helped. And that can be, I think, implemented without the fear that now you have hundreds of family storming the ICU, so to say.
Another comment from the Facebook is the challenge for the ICU nurse who want the family to visit and see loved ones, but they don't want them to be exposed to COVID, especially for families who are considered high risk. And I think this has probably been quite an issue in some communities, in some countries where you have multiple family members, and that's quite a balance, isn't it? Balancing out that understanding that people want to visit, but also not wanting to put them at risk, so they end up in the next bed, as it were.
I've read a lot about units that started using a telecommunication inside the COVID-19 and between the families. And we started doing this in September using our social workers who made the connection using an iPad through families. So this alleviated a lot of stress, and especially with families who were immunocompromised and couldn't leave. And so again, it opened opportunities, things that we had not thought of before. So,
and certainly we had a couple of staff who needed to shield for their own health reasons, who we suddenly turned into family liaison officers. We'd never had the opportunity of having that before. But actually their role was very much to create links with the families, have conversations, and then arrange FaceTime calls. And what was really interesting, so they never went into the COVID end, but the iPads obviously did. And then we were able to show the family the patient and the room and what the environment was like, because I think that's particularly when people are very, very unwell, one of the assistance we all find to having some of those conversations of we're really concerned and things are not going as well as we would like is that visual the relatives get of, oh my goodness, so and so, they look awful. And actually then you can then lead on to some of those conversations about how things, that we've got concerns about how things are progressing. And when you haven't got that visual, that makes things much more difficult, I think, for relatives to be able to understand. How do you feel the media helped or hindered us during this in terms of families? And I can see Christian wanting to go like this, because I think for the first time we found critical care was, I don't know what it was like in your country, but it was in the headlines, and everybody knew what ICU was all about, and everybody had an opinion about ventilators. Do you think this helped or hindered families being able to watch the news and think, oh, well, okay, I can visualize my loved one, because it must look like the news? Do you think that helped or hindered us?
I think it was awful, and for many reasons. One, we got absolutely battered asking for people to talk to, relatives and patients, and most of the patients just weren't in a place where they could really sort of cope with being talked to, and we didn't want to re-traumatize them. But also some of the past patients, pre-COVID, who maybe had got on top of their post-traumatic stress disorder, everything like that, they got re-traumatized by watching the news and seeing the environment in intensive care all the time. Every time they turned the television on, they felt like they couldn't watch the television in case they got hijacked. And some patients and relatives felt the same, that it was too much. Yes, a little bit, so that the relatives knew what was going on, but it was all the time and for prolonged periods. So it got to saturation point, basically.
I think it did a very, very good for ICU nurses, the media.
Yeah.
Yeah, we have a study that said that was the most important factor in retaining nurses in the ICU was the media exposure, because they were treated like celebs, or they felt that they were celebrities. So in one way it was, yeah. So, yeah.
I think that's been slightly different in the UK. And do jump in on the chat, folks, if you disagree with me. I think in the first wave in the UK, we were heroes. We had capes. We were, We were saving the world. People were outside banging pots and pans and saying, you know, what an amazing job we were doing. As the phases have moved forward, now we're just a bit of an irritation because people want to get their high-risk surgery, absolutely rightly. And so it's moved from this sort of Dunkirk spirit, everybody behind the healthcare workers, to actually a little battle worn with it, and it's quite interesting over the phases how that's changed. Has that been the same in other countries, do you think?
Well, the thing with celebrities is that they always have paparazzi. So it was nice pots banging, but at least in my country, I think that was about it for the moment. Nurses were promised some extra wage on tops. I cannot say generalize that, but if so, it took a long time to arrive because there was too much debate and too much rules and too much what have you, and we Germans are very good in sinking everything into rules rather than into deeds or into doing. I can understand that families are worried by what they see on television, even though it may not be their country or it may not even be their region. On the other hand, I'm a little skeptical because people see starving children and civil wars and what have you all the time. But they don't think that that's happening in their next garden. So I'm not sure what this is about. I mean, this world is not everywhere a good world. And unfortunately, people do die. But they've died before COVID, and they will go on dying for terrible things. So if anything, it deterred.
Yeah. Do you think people became immune to it in the same way as, you know, you're describing the very often pictures we see of starving children and wars and so on? One of the things in the UK was, so they had all these reporters in PPE going into intensive care units, and we would have relatives saying, well, hang on a minute, how is it okay for a reporter to have PPE and go in and walk around a unit where my loved one is and I'm not allowed to go in? What do you think about that? Personally, I think it's a fair point.
No, we let families in before reporters. We started letting families in at the end of the first wave. One family per day at one point. So families were slowly let in. By the second wave, we had to police everybody. But we had families in from very quickly.
I didn't see a reporter, but again, this is speaking only for a small number of hospitals. And in going back, just for 2 sentences, Carol, yes, we get unfortunately used to those pictures in the media, and therefore it takes away whatever deterring effect it should have. So it deters, in the end it deters because we're not paying attention to it anymore, which I think is not what it should do, if anything. Plus, unfortunately, in Germany, we have a great number of non-believers, and you could tell them about you could show them all those pictures and tell them that people die from corona, and they tell you, oh, you know, it's just another flu. So whatever they see, if they believe that that's not happening, and that's not happening, you can show them whatever you want. It's like this warning on the cigarette boxes saying you might die from smoking. Well, those addicted will keep on smoking. That's it.
Yeah, no, that is true. That is true. So what do we think about, certainly in the first wave, there was very much a perception that the ICU team became the family for patients because relatives weren't allowed to visit. What do you think about that as a, well, A, it's a privilege, but B, also it's a burden for for staff. What's your perception on that as something that we were sort of thrust into in the first wave? Is suddenly we weren't having the same interactions with family, and were very much more advocates for the patient maybe than we might have been previously.
I think especially when we're talking about end-of-life care and the patients were dying by themselves, you really had to go out of yourself as a nurse and into yourself as a loving and grieving, spiritual, anything that we could do to make this as insufferable as possible. So this is when I really think we went out of our roles as being nurses and moving into the role of a loving, caring family member.
Do you think that we were prepared for that?
No. No.
I have a slightly different perspective. A lot of the patients that have been coming to support groups had really quite dramatic delirium, periods of delirium, and their sense was that nobody was there for them, and basically everybody was trying to kill them. So the PPE didn't help, because a lot of people thought they were being looked after by aliens, and were sure that they were trying to kill them. So I personally don't think for the patients it fulfilled a role in the way that we think it does. It maybe does for the relatives, particularly at the end of life, that they knew that somebody was there with them.
Christina did a lot to the staff. I think end-of-life care in the end you do, especially for the family, but we could not fathom letting someone die like on the bed by themselves with nothing. Yeah. So I think it did much for the staff that we moved into another role.
Yes.
Do you think that there's any fallout from that for the staff, having a dual role as caregiver and also as that person who is with somebody at that moment at end of life?
Yeah, I mean, it may, and there's reports that it does cause moral distress. Nurses and physicians weren't even able to fulfill their first role, at least often subjectively, because they couldn't do what they thought they needed to do. And then comes the extra role, being the liaison officer or the grieving, very personal support person. And then perhaps comes the third role, which is doing something for administration. So of course, some of us were overwhelmed.
That's very true. One of the questions that's coming in on the chat is is asking us to debate what were we frightened of working in ICU. Why did we have this such a restriction on family visiting? And that's a question they're asking us to debate. Was it appropriate that we were as frightened as we were around having people moving in and out of the ICU?
I think at the beginning we knew so little about how this virus is transmitted, and we were constantly afraid that we were going to get sick and die, and we wanted to limit the exposure of as many people as possible. I mean, in one sentence, that's what I would say, because we just didn't know enough. And as time grew and we knew more and more, we were able to protect people better.
And what about having families in PPE in those areas where PPE was very limited? What do we think about that? It's a difficult balance, isn't it?
Yes.
But can specify that again about? Family.
So in relation to PPE, when certainly in the first wave, in various areas in the UK, PPE was in very short supply. So there's then a balance between, if you want to have family in at the end of life, which you all do, then there's a balance between areas that didn't have enough PPE, and do you need that PPE for the staff, or do you balance that with the needs of the loved one to be there during end of life? I don't know if that's just a local, a sort of an issue in certain areas in the UK, but that certainly generated quite a lot of debate in the first wave for the UK.
So that's a situation of scarce resources, right?
Yeah.
Yeah, then you need to have prioritization rules.
Yeah.
At where you work.
Yeah.
I mean, the Supreme Court is not going to decide on that, and if it decides delayed.
Yeah.
So, and what do we weigh here? We weigh the nurses and physicians' ability to help many against an understandable wish of the families to be with their patients. And that is very difficult, yet in the end, utilitarian speaking tells us that we have to protect the staff.
Yes. It's very difficult. There's also another message coming through saying, do we feel that there was a prevalence of mixed messages being delivered to families due to emergency work rotations, enhanced shift work, along with some unavoidable breaks in the continuity of care being delivered by the same medical staff? If the same experiences were felt, what pragmatic approach were you able to do, considering the high burden on everyone? And I think some of this probably relates to, again, the media reporting that surgeons and various others all drafted in to manage and support care in the intensive care unit. But do you all feel that there was a prevalence of mixed messages that possibly increased anxiety to relatives and potentially patients?
I certainly was aware of that, talking to relatives from the other end, that and you mentioned earlier about liaison, the liaison role, and actually you could see the difference between relatives where there was a liaison, so that they actually had quite clear information what was going on, and relatives where there wasn't a liaison, and in some cases they weren't even getting daily phone calls. They were just sat at home wondering whether they should phone, and then feeling guilty if they did phone because they were taking somebody away from the bedside. And we made quite extensive use of recommending relatives like that to contact PALS, Patient Advice and Liaison Service, which works within the NHS, so that they had somebody who could actually advocate for them that they needed to get some information. So there was a real sort of mismatch of, all sorts of levels of information actually coming out of intensive care to relatives.
Do you think that we coordinated that as well as we could do? Bear in mind it was a pandemic, nobody planned for it, none of us asked for it. Whether actually the thought about how those interactions with families, do you feel that we planned for that in the same way that we plan for increasing numbers, increasing requirement for ventilators, for pumps, for staff? Do you think that we gave enough thought to actually, okay, a core part of what we actually do in our roles is to care not only for the patient, but also their loved ones? Looking back, do you think in our individual countries that actually we planned for how we interacted with relatives with the same degree of precision as we did in terms of workforce and equipment? And was that right or was that wrong?
I would certainly say in the UK it was a bit piecemeal, and that for some people it was put on the back burner.
I think in Germany, sorry, Julie?
I think it was just reactionary. We didn't plan anything. We just reacted to a situation that we were in. And then we had to kind of find a solution, and there was not really extra people around to help with this solution. So we had to use extra kind of personnel, volunteers, elderly people that did everything, telemedicine. So it was just reactionary, in my opinion.
I think that is a good word. We tried to react to an unforeseen and unknown problem, at least in the beginning, of a magnitude that I think in the beginning really was not seen to strike us. And I would think by default, we did what we did, first of all, for the patients. That's our main job, right? I mean, this is what we fall back to. If we don't know well, we go back to what we've learned. Take care of the individual patient or patient groups. Then we try to increase the material, if possible. And then we understood, you need personnel to work that material. The ventilator does not come with the nurse in the package. Therefore, we tried, in some places more, in some less, to have other workforce to do the things that we thought they would be able to be doing. At least for my institutions, we did not try to make surgeons the intensivists, but we tried to have their help as much as was realistic, so to speak. And then, at least in my opinion, we thought, oh, wait a minute, patients have families. Not because we wanted to dismiss the families, but that was not in the first line of our thinking. And it's nice in hindsight to say should have, would have, could have. But if you're put into the position and the situation, you do what you do best, which is caring for the patient. So this is not an excuse, but it's perhaps an explanation why it happened as it happened.
Do you think, is there anything that's been published that really sort of sticks out in your minds at the moment around caring for patients and their relatives during COVID that you'd like to share with this webinar that sort of sticks out and resonates with you, Julie? Any particular research that you think actually this really represents what it was really like?
I'm reading a lot of, I'm just concentrating on what I've read about how different countries and different ICUs dealt with families. And more and more is coming out about telemedicine and using iPads and using technology like this in order to, not just for visual, but also for audio, that they could speak to their loved one through the iPad or through some sort of technology. And that's what I've been reading, that people are talking about the technology they use. I don't think there's been any research on what the families went through. I haven't seen what the families went through. Where now a lot of research is coming about the long-term COVID-19, what's going on with these patients long-term, even the mild COVID patients. So, but families I haven't seen a lot. Have you? Any of you?
No, I haven't, but I just wonder whether actually it's an area that we will see more data on if it's collected going forwards, because we don't really know the impact of what has been done during this period has had in the positive or in the negative. I think that's because there will be some positives. There will be some relatives, and correct me if I'm wrong, there will be some relatives, Christina, who actually maybe were relieved that they didn't have to come to the bedside, because for some that is very traumatic, and actually they've then had permission to have interaction with the ICU team in a slightly different way, and not feel the guilt of I actually can't be at the bedside. And maybe some of the interactions that we've developed with timed phone calls, timed FaceTime, and those sorts of things are things that we probably ought to keep going forwards, because actually then you've got a whole series of tools in your armory that actually reflect individuals and their families and what they might need.
I think one of the things that struck me was once you had those sort of virtual visits, it wasn't just the next of kin that could actually be speaking to the patient. There's also children in the family that hadn't seen a dad or a mum, grandparents, and they could join those visits and actually speak directly to the patient. So when we talk about family, we're not just talking about adults, we're also talking about children who would, you know, are left thinking. I mean, certainly we found that quite a lot of the kids got quite guilty because they thought they'd given their dad or their mum COVID somehow and that they were responsible. So you have to recognise it's not just the adults that this affects, it's also the children.
Yeah.
Andrea, what do you think? Is there anything that you've read that really resonates with you around this whole period that sort of feeds into this debate?
I agree with you that, at least to my reading, there's still a paucity on the effects on families, which probably also has a methodological reason. What struck me most actually is two things. One is how to prioritize or triage. There's been a lot of literature since in some countries and places that really had to take place, unprecedentedly so, and also the increasing literature on the what they call post-COVID syndrome, which we didn't think about in the beginning, again, because we were confronted with the actual problem now. We could not think in the beginning of the past or the following 8 weeks or 6 months. But I think it is very important because this is something we will have to deal with, even though the numbers of the acute COVID patients, at least in Germany, have dramatically gone down, like I said.
Yeah, they have in the UK too. In the live chat, they're talking about the Lifelines project in the UK. Have undertaken some research on the impact of visiting restrictions and the role of remote visiting. So that'll be quite interesting, I think, to see, because I think there'll be some obvious negatives, but there may be some positives too.
Yeah,
what are they testing? What are they researching?
It just says the impact of visiting restrictions and the role of remote visiting.
Very good.
So I think that will be interesting going forwards, because I think throughout the whole of COVID, not everything that we've learned is necessarily bad. And I think there are some things that to come out from this that actually by necessity, we've had to rethink the way that we do some things, and maybe some of that isn't a negative, and that actually potentially that's a positive. What do you think of the? One of the things I was talking to Christina about before is that we've got. I don't know about Julia and Andre in your countries. We've lost quite a lot of staff. Have left during the COVID period, nursing staff, and we've got a lot of new staff. And usually when a nurse starts newly in the intensive care unit, and forgive the way I put this, the exposure to interactions with families at the bedside is sort of part of the suite of things that you have to understand and be able to care and deal with. And we've had quite a lot of staff come to us not with an ICU background who have been concentrating on caring for the patient and understanding all the complexities of that. And now the conversation with families were at 2 o'clock or 3 o'clock or whatever. So it's sort of very sort of in task terms, clearly defined. Whereas now we've got relatives sat at the bedside and asking questions, and the interaction is different. Do you think, what do you think about the impact of that in terms of education and pressure for those staff?
I think, like I would assume, many countries, we've had also a considerable number of nurses leaving the job. I haven't heard of so many to come in. So we would be happy to have the same number coming in after a little while as the number that have gone. By education, I would think that is usually difficult to integrate into a new group. However, perhaps I'm very cautious because that's my thinking and I have no data to support that. But perhaps coming in with a somewhat lesser, may I say that, burden in terms of having to speak or be available for family perhaps is easier, but that is only an assumption and nothing more.
I would agree with you. What do you think, Julie? I think in some ways, when you're new to intensive care, actually just understanding caring for the patient in the bed space and everything that involves, distressed families is an additional overlay to that.
I think we have to stress, what I do with new ICU nurses is stress the fact that the family is not there to criticize you. If they're asking a lot of questions, don't take it as they're criticizing. Just take it. You have to understand that it's their lack of knowledge that's making them insecure, and it's your job to fulfill that knowledge gap. But I think that's where nurses don't want the families around because they think that they're being criticized, and that's not true. So that's what I couldn't say that enough to a new coming nurse.
Well, then you've educated your families well, Julie, in your country.
No.
My understanding sometimes is, I have to say, not with all families, of course, but there are families who think they need to educate the nurses.
Oh.
And they think that they need to educate the physicians as well. And they ask the same question 10 times until they get the right answer.
Until they get the answer that they want.
Yeah, exactly. So I agree with you. We should, in principle, say this is a knowledge gap that we are apt to fill. However, we all know about the at least seemingly difficult family.
Yes.
Yeah. Do you think we prepare staff adequately for that, even in non-COVID times? No, I would agree. Would that be your impression, Christina, from slightly from the other side? Is how do relatives and ex-patients view those interactions, particularly if you've got a junior or inexperienced nurse at the bedside?
I think relatives do sort of get to know that there are people that they can trust to speak to them clearly, and others who maybe aren't quite as good at it. They do become sensitive to the person that they would prefer to ask. And that's not necessarily the person that's at the bed space at the time.
Yeah, I think that's very true. There's comment on the chat saying that they believe Julie is absolutely right. But how do we make sure that these junior nurses get proper training on these issues during difficult times? It's very difficult, and I think probably it comes back to Andre's point of when things are challenging, we come back down to the primary role, which is caring for the patient.
Yeah.
I think the other thing that went out the window with COVID was the fact that a lot of units stopped doing ICU diaries because of the worry about cross-infection. And one of the roles that relatives play in that is actually putting the family perspective in the diary of what's going on, not just, you know, the technical stuff about what's happening to the patient, but also what's going on at home and stuff like that. So there have been a few units that have continued with diaries, even during the height of the crisis, but they were missing that element of being able to tell people about the home life as well as what was going on in intensive care.
So one of the things I set up in our unit was an email address, which is only okay for people who are email savvy, but was thinking of UICU. And so the role of the family liaison officer was to explain how that worked. So it's sort of one way, no replies, but actually encouraging them to send in, this is what's happening at home, scan in pictures from the children, messages from friends, family, or whatever. And then what we would do is print them out in the COVID ICU and put them up, so that we'd got that sort of liaison. And it's something that we wouldn't even have thought of before, but families always want something to do, so they're part of the process, and that's where the diaries are fantastic. And not being able to physically write in them, and okay, it's not quite the same writing an email, but at least I wasn't sure that families would go for it, but actually we had masses and masses of emails and scanned pictures and snippets from newspapers, all sorts of things that came in for patients on that process. And that's one thing that we benefited from COVID, that we will probably keep as an option for some family members who maybe not want to visit.
Carol, who answers all the emails? Who answers?
Nobody.
Do you have a designated person?
No, there's nobody. It's a one-way mailbox. So the family liaison nurse will explain that it's a one-way, so that nobody answers it. Otherwise, it'd never get done. So it's just a way of sending in, okay, this is for my loved one. So they put the name of the patient. It comes into the email, and then the family liaison, it gets printed off in the COVID ICU, because there's all this issue around paper and so on. It gets printed off in the COVID ICU and then put in the patient's diary, or put up in their bed space if they're awake, so that it can be read to them and so on. So that worked really well as an option. And we also did the twin hearts thing, usually at end of life when relatives couldn't be there. We had the local community knitting hearts, and we have thousands of them now. So twin hearts, two identical hearts, and if family members couldn't be there at end of life, what we would do is place one heart in the hand of the patient who was dying, and then we usually send bereavement cards anyway, but we'd send the twin to that heart to the families with the bereavement cards. And that's something that we've carried on. Now COVID is much less of an issue, but it's something that people really seem to value. And I say the local community, we put a shout out, please, can anybody, this is the not recipe, this is the pattern, please can you knit some of these hearts. And then of course infection control were like, oh, you can't have this, so then we had to go through ultrasonic sterilizing them and all the rest of it. But actually it's something I think that will keep, because that was something that people found very touching, to be able to receive a twin from, and when the patients left us, when they'd passed away, the heart stayed in their hand, and so that sort of contact seemed to be something that people valued. Any other similar things to that in your units that were sort of that kind of developed almost by accident? But I think it's something that we'll keep. And I can't knit, thankfully.
You can't make, sorry?
I can't knit, so there would be very strange hearts if I was doing but it is something that people really seem to treasure in that bereaved time.
No, we were not that inventive.
I think they both sound excellent ideas. And it's really strange, because some of the patients who didn't have a diary, they actually found out how to print out all the WhatsApp messages that had been sent about them during the period when they were in intensive care, and trawl through that instead. So that's how important the diaries are to patients. So that sounds a lovely idea, to actually allow them to email in messages from home if they can't be there, because there's always going to be somebody who can't make it, who can't get there. So, they may be in a different country. So it's really sort of, I'm really struck by that.
I say it came to me, and I thought, why don't we do this? And then actually making it the emails one way was probably the best advice I was given over that one, because then there isn't that pressure on waiting for a reply for the relatives more than anything else, because it's not just the pressure on the staff to reply, but it's the worry that people are waiting for you to reply, whereas it was explained to them that there will not be a reply. It's stuff that you can send in, and some of our relatives were very, very prolific in the amount of stuff they sent in. But that was great, because that was a focus for them. There's a message coming in on the chat. It says, on the diaries, there are options to use WhatsApp as an alternative. And I think that's what you're referring to, is sort of the WhatsApp sort of benchmarking time and progress. How was technology used for you, Julie and Andre? So FaceTime, WhatsApp, what was the most useful ways of communicating?
In our country, WhatsApp is so prominent, and we had WhatsApp groups, which was great because a whole family could be together at the same time during the same WhatsApp. So we encouraged that. So it wouldn't be 12 phone calls or 12 WhatsApp calls. So we would encourage a family group, and then everyone would see them together. We would encourage them to sing a family song together. So, and we had many tech companies donating the technology itself, the iPads or the tablets. So this is by far what we used in many, many units in this country, the WhatsApp.
Cool.
And is that still carrying on?
Yes. Yeah. What about the same thing when I was the nurse family liaison in the morning, and we would initiate the calls? I would make sure that when I started the call, I say, do you have anyone else you would like us to talk to together in a group? So it kind of started, that would be the best thing. So I wouldn't get 10 or 15 calls a day. So that's the advantage of having a WhatsApp group, that you only have to really talk to, you have to relay information once, and then everyone hears everyone else's question.
I think that's a very prudent way to do it. Unfortunately, we obviously haven't been quite as intuitive, and I don't know about any tech company that would have given us the same as they gave to you. But I think that's just because we didn't ask.
Yeah.
So it was still mostly telephone, especially, I must say, in the group of elderly patients or their spouses or partners who perhaps were a little less used to using other technology. And whenever we could, I think we still tried to have face-to-face. And again, the big step was the possibility to have people tested, test ourselves and have people tested.
What I would like to add about the WhatsApp is we did a huge study on how the WhatsApp facilitated teams, because the teams were very, very, very non-cohesive teams. We had 2 nurses from dermatology, a nurse from pediatrics, all working on a shift. And you had to make this into a team. So the WhatsApp group, I'm trying to get it published now, on team cohesiveness using the WhatsApp as a group. Is it more of an intrusion? Did it help? Did it hinder? What exactly? Because we kind of get carried away sometimes. Happy birthday, happy whatever. And it doesn't have anything to do with your professional group that you're attached to. But this is an added advantage and benefit to the WhatsApp group is being able to build a team. And the only way these people could recognize themselves is when they looked at the WhatsApp and they looked at the picture, the profile picture of the person, because you didn't know what they looked like.
Yeah.
And it served the purpose of what we would call social support in the coffee room during the break, which we couldn't do. So using that WhatsApp group had a huge amount of impact on building teams that were a non-cohesive team.
One of the things that we noticed, there was a project called a 360-degree virtual ICU bed space, which was actually being used to train non-ICU staff about the bed space before they actually came into ICU. And that had been developed fairly rapidly. And I just happened to see it on Twitter and got in contact with the people that had developed it. And they were very interested in actually developing something similar for relatives and patients. Because at the moment, patients can't go back to see where they were in the bed space in ICU, which is often a really important tool for sense making after they've left ICU. And so we got a group of relatives and patients together, and the team is the London Transformation and Learning Collaborative. And this is all free. It's open access, and we're on the final draft now of a bed space for relatives and patients to look at. And there will be sound that will go with it, but they can choose whether they have the sound or not. And there will be description of all the equipment, so ventilators and hemofiltration machines, everything like that will be explained, but they have to click on it. They can either look at it, so that there are various levels. If they find it too overwhelming, they just look at the superficial level. So technology really opens up so many different ways of dealing with patients or relatives, even down to the fact that there's a group in the Netherlands that have done a project with virtual reality to help patients come to terms with their memories of intensive care. So from necessity, it had to be done. But now it's actually opening up new pathways for the way things can be done.
And certainly, so obviously what we did in the C19 space, which was an ESICM EU project, that was about training non-ICU staff, but actually some of that content in terms of the virtual reality of this is the bed space and being able to click on the equipment and stuff is very translatable to patients and relatives if they choose to want to interact with it. So I'm being asked somebody is saying, doesn't say who it is say that they've worked on a digital diary that's accessible from any device. Are there any other digital innovations known of in family policy? So you're talking about some virtual reality work. Anything else? Is there anything else out there that you're aware that would be really useful to share?
We have a forum for patients and relatives on Health Unlocked. If you want to find it, anybody can register as a professional or as a patient or a relative. There are contributions from all over the world, so that people can post questions about. It might be that the patient is still in ICU and a relative wants to ask to get more understanding of what's happening from other people who've been through the same thing, or from healthcare professionals. Or it could be that relatives, patients are saying, I had these really weird dreams and nightmares, and has anybody else had the same experience? And as I say, we now have members from all over the world, not just from the UK. We don't have any foreign language ones at the moment. It's predominantly in English, but I can't see why you couldn't start a foreign language stream to the same forum, so that other people can actually benefit from it.
I think you're absolutely right. I'm being asked that we talk about media being applied to conscious patients and being able to use WhatsApp or a tablet to be able to share, even if patients are not able to talk. And what I'm being asked is, what can we do for intubated patients, and how do we alleviate patient anxiety, relative anxiety, if we've got, if we're showing relatives their loved one who may be prone, they may be paralyzed, they may be, but certainly unconscious. Any thoughts on how we might approach that?
There's a lip reading app being developed at the moment, and I'm trying to think where it's being done. It's certainly in the UK, and that would actually allow anybody to lip read a patient. It's going through various stages at the moment, because it has to take account of things like accents and characteristics of the way people talk. But if it can be developed, it would mean that you would be able to lip read a ventilated patient very easily. Possibly not one who had a tube in, although they do say that they could eventually, and even with an oral tube, be able to develop something. But certainly somebody who had a tracheostomy. So that's in the process of being tested at the moment. And I think that would be a really useful tool.
Okay. How often do you think we should do video calls with relatives? How often? How much is enough, and how much is too much? Andre, what do you think?
Yeah, I'm laughing because I'm not quite there in my understanding whether it is the number, or rather it is the length of time that we give, and the completeness, so to speak. And completeness is not meaning rattling down lab values, but giving the relatives time, following the value template by Randy. So if we were to speak with patients and families every second day before, without any better or other reason, it should be the second day now too, if we have the time and if we have the means. And if it is necessary twice because the situation changes, then it must be twice.
Yeah, no, I would agree. Julie, what do you think?
Yep.
How often?
Yeah. If there's a change, then it has to be more. We usually set the routine and we say to families what they should expect. They'll expect once a day from us at 2 o'clock from the physician, early in the morning from the nurse, and that's the routine, the standard of communication that we give. And if there's a change, we'll of course, the schedule is flexible, but that's the standard of communication. And once you have, these are the rules, this is what it is, and if there's any change, of course, we'll be flexible, but yeah, that's what we usually do.
Yeah.
That's what we did in COVID, the same thing. At 8 o'clock, a nurse would call everybody, and then between 12 and 4, the physicians. The attending, the consult, the head, the guy in charge.
Yeah. Andre, did you find that having to do telephone consultations as opposed to face-to-face, certainly during the first wave when things were slightly less organised, did you find that much more difficult to create that relationship with the relative?
I think that's a very pertinent question.
Impertinent?
No, important.
I thought you said impertinent. I was going to say I wouldn't offend you for the world.
No. Timely and important. I'm sorry. To me, oftentimes the very first encounter to learn about the patient is a very decisive one, and I have to say that doing that over the phone appeared to me a little more difficult. However, again, if we make time and know that the family has time and is in a situation where they can, so to say, speak in peace, not at their workplace, for instance, then once you've established the contact, it's not so different, I would think. What is different is when it is about end-of-life care decisions. That is more difficult over the phone, but that's my subjective assessment.
Yeah, and that's my thought, because we lose that all the non-verbal cues and so on. So, would you advocate relative interactions on FaceTime or Zoom? Do you think that helps?
I think it might help. We have not done that over Zoom, but I can imagine it does help. It doesn't substitute, I would think, for face-to-face, but it is a level more, if you will, a dimension more.
Yeah. No, I would agree. So we've got about 5-10 minutes left. What I'd like to ask each of you is, what would you keep and what would you have done differently if we were to hit COVID right now and we had time to plan for this roller coaster that we've all been on? Julie, what would you keep and what would you plan for?
First of all, I'd like to say that from the beginning, I thought we should all take photographs of what the family area outside the COVID-19 looked like, because it was different from the regular ICU, and there were so many signs that said, beware, caution, don't come close, this is contagious. And it looks so, even if you don't know the local language, these signs were so scary. So I'm thinking from the beginning that we should take pictures of what this area looks like and keep them, and because we're going to forget what it looks like, and keep these pictures and even do a qualitative analysis of what this picture makes me feel like with the families. And that's what I would like to do. And of course, we would try to make the family area as homey as possible, but with all those signs, it's so scary. But I would make sure that there's a place for families to sit, that there's something for them to drink, that there's a nice quiet area, as we do in the regular ICU. We have a huge, wonderful area for families in our ICU, regular ICU, not the COVID-19. So I would definitely plan a way that we could see families face to face, plan a way that we could make sure that they get up to date with either WhatsApp video or FaceTime or Zoom, and establish this from the beginning. I think that's it.
Yeah, no, I think you're absolutely right. Intensive care was terrifying to everybody and to other healthcare workers, not just to any relatives. You know, we had a lot of hospital managers and others who wouldn't come anywhere near because this place looked so terrifying. There were benefits to that, I have to say, in certain quarters, but it, you know, that sort of that visual that you get, I think, isn't something we should underestimate. I think that's really good advice, that we should be maybe planning for the future, hopefully not to happen again. But actually, simple things like that might just make things slightly less terrifying for relatives. Andre, what have you learned that you would keep, and what would you do differently if you had time to plan for a pandemic?
I am happy Julie said that about the environment. And I would hope that that could be done also. I think I would try to establish liaison officers from the beginning, so that whoever this was going to be, nurses or physicians or whoever, would have a chance to grow into that responsibility, so that we would have a schedule, shall I say, or a schedule for those staff to be better able to fulfill their role, which for most of them would be a new role. And if we did that earlier with the help of technology, which we in our hospitals that I can speak about have not done, then I think we would have an improvement. What would I keep? I think I would still keep the understanding that our first goal in times of uncertainty is to care for the patients and for each other.
I think those are very useful foundations, aren't they? No, I would agree. Christina?
I think the whole thing about, as I said earlier, that that blend of doing face-to-face support groups, of interacting with the local ICU. So some of our patients and relatives actually will speak to patients directly in the ICU. They've built up a rapport with the local staff, so they will do video calls to reassure a patient who maybe is struggling. And that sort of, you know, doing a blend really of the in-person stuff and keeping some virtual aspect, which allows people who maybe can't travel to be able to join in and get something out of the local meetings that are being run now.
Do you think we're going to be seeing a lot more interaction with post-COVID patients and their families going forwards, because the interactions have been different?
I think that there are a lot of patients and relatives out there that are really struggling, and follow-up disappeared completely because obviously the staff had to move back into the intensive care unit. Rehabilitation wasn't widespread anyway, but it vanished. And some units have now started to do virtual rehabilitation classes, running follow-up over things like Teams and WhatsApp. So And for some people, I think if you look at somebody who lives in the wilds of Wales and finds it very difficult to actually travel to an appointment, it may be that they would prefer to talk to a consultant after they've left intensive care through a video call rather than actually physically going there. And maybe, you know, they don't have a vehicle, the buses run twice a day and it's very difficult to get there. So there are aspects that are valuable and give patients and relatives more choice.
Do you think potentially we might reach more of those patients who don't access follow-up services, and there's a proportion who don't, because maybe they can interact in a way that they feel more in control of? Yeah.
I mean, for some patients, they don't want to go back to the hospital because it's too frightening. So being offered a virtual follow-up
alternative,
probably, yeah, it's definitely preferable.
Thank you. We need to round up now. I'd really like to thank Julie, Andrea, and Christina for a and hopefully an interesting and enlightening discussion. Many thanks to everybody for posting their questions for our panel on the social media. I think we've learned some useful things from each other about what we've learnt, what we would carry on doing, and what we probably wouldn't carry on doing. And I think there are lots of positives that we can take forwards to assist us in planning, in caring for our patients and their families going forward. So never waste a crisis, they say. And I think there's some things that we can definitely take forward. So I'd really like to thank all the panel very much for their time and their expertise this afternoon. Many thanks, everybody.
Thank you, Carol.
Bye-bye.
Thank you very much. Good afternoon.
Thank you. Bye-bye, everybody.